I am so excited to have our first in-person distinguished Sam Regenstrief lecture since COVID. So woohoo, we're back together in person, yay. So it's been a while, so I'm gonna remind everybody that the Sam Regenstrief Distinguished Lecture Series is named for our founder, along with his wife, Murdy, and after the establishment of the Regenstrief Institute in 1969. Mr. Regenstrief recognized back in the 60s the need for equitable healthcare. This example relates well to today's speaker, and I'm so excited to invite my friend, Dr. Typhanye Dyer, to present. Dr. Dyer is an associate professor of epidemiology and biostatistics at the University of Maryland School of Public Health. She received her doctorate from UCLA in the School of Public Health and completed her postdoc training at Johns Hopkins. Her educational training is in infectious disease and social epidemiology, as well as community health, particularly focused on community engagement research. Her work in integrating theories and innovation and methodology from disciplines, she strives to understand the broader social and structural processes that impact health and community. As an epidemiologist and health disparities scholar, her research examines the influence of social, psychological, and behavioral factors on HIV and STI risk in Black populations. She has over 20 years of experience conducting research exploring HIV and HIV-related outcomes among sexual minority men as well as women. The majority of her research applies the concepts of syndemics, which is a new word for me, but it's the complex, intersecting, and synergistic psychological and structural barriers in society. To that lived experiences, it also involves justice. So regarding Black women, she uses a familiar framework to develop an understanding of the impact of social position and intersexual stigma on syndemic physical, social, and neurocognitive frailties for older cisgender Black women living with or at risk for HIV. I am so excited to have Dr. Typhanye Dyer speak to you today on her work, so help me join her in welcoming her. And we have, in addition to the folks here, we do have people online too. So we'll monitor that at the end.
Okay. Thank you so much, Nicole, for that wonderful introduction. Thank you everyone for being here. I met Nicole not that long ago, and I was blessed to be able to do a short talk on the use of race in health services research. And Nicole was so kind to invite me to the Regenstrief, it's Regan or Streef. And I just learned this like 2 minutes ago, and then I messed it up. The Regenstrief Institute. And so thank you very much for that very warm welcome. You might be wondering why I have this book. So I got this book like last week. Okay, it's Emily Post's Etiquette. So I was thinking this book was going to tell me, which fork was the right salad fork, about using your manners and things of that nature. And it is around that, but it actually kind of spoke to me a little bit in terms of what we're going to be talking about today. Because the real basic foundation of our interactions with one another, we're in a relationship right now, right? So it's about basically being mindful and treating people the way that you would want to be treated. So basic etiquette is just be mindful in the ways that we interact with one another, the ways that we speak to one another, and the ways that we address one another. And so again, thank you so much for having me. I am Typhanye Dyer. I use she, her, and queen pronouns. And I am an associate professor of epidemiology at the University of Maryland in the School of Public Health in College Park, not to be confused with the School of Medicine, which is in Baltimore. So some learning objectives for today. Some of the things that I hope you come away with are an ability to define what unconscious bias is, okay, and distinguish it from conscious bias. To be able to list the different types of unconscious bias, I'll go through those. Describe methods to mitigate bias in our practice and our research. So a lot of people might be clinicians, you might be forward-facing with your patients, your clients, if you're a therapist of some sort, or you might be someone who's conducting research in the community, and so you are still forward-facing to folks in the community. Defining stigma and the three interrelated concepts of stigma: labeling, stereotyping, and othering. So we'll talk a little bit about that as well. Defining the social determinants of health, differentiating between equality and equity, okay? Explaining how identity is linked to diversity, define cultural sensitivity and how it's distinct from cultural competence as well as cultural humility, and then listing this is a lot of stuff, and then listing sociostructural barriers to healthcare. So I'll take you on a little journey with me. Okay, so where I want to start is the evolution of terminology in research and clinical practice. So this is sort of like sort of springboarding from the talk that I gave for Dartmouth, where I did go through the historical context of race and the reasons why we use race in research as a variable, the ways that we measure them. And so without getting into the nuts and bolts about that, because I want to talk about equity, I will say that the foundational rationalization for using race started with good intentions, right? So it's a way to say, well, there are different exposures or different experiences with even social and environmental factors that may impact a certain segment of the population compared to another population. And so those people might look different in certain ways. And so that is sort of the reason why you may be at higher risk for whatever the outcome is. We know that that's not the case, right? So we know that biologically we're more alike than different, and it's those social phenomena that might be on the shoulders of certain populations that actually put them at greater risk for whatever health outcomes we're interested in. So again, when we think about the ways that we address our clients, our patients, our participants, we want to be very clear about some of the adjectives that we use to define and describe people are oftentimes stigmatizing to them. And we'll get more into this a little bit when I talk about stigma. So some examples, and I know that the NIH has published some literature around terminologies that we should be using, as well as the American Medical Association as well. So instead of defining people in terms of what their condition is, instead of saying, oh, you're a diabetic, you might be a person living with diabetes, or calling someone infected with HIV. And I see this a lot now in grants and proposals. And when I'm sitting on study section, it's something that I'm very critical of. So people are like, I am not my disease. I am someone who might be living with this particular outcome in my life. And then of course, psychotic, to define someone experiencing psychosis. And so again, thinking about what is it that is happening in people's lives at this moment that put them in that category of whatever it is that we seek to understand better. So again, even thinking about minorities. Okay, so this slide I made this slide before we were starting to use terminologies like minoritized communities, right? Or communities for which they might be in some minoritized status instead of saying you are a minority. So context matters. So when we think about geography and minority status, a lot of times in the United States, we center ourselves, right? But I think it's very important to be critical of that and think about the fact that in a global context, people that we might think are minoritized in this particular country and on this continent it's not the same if you travel enough. And those of us who've traveled know that we see differences, right? Not to mention, the term itself implies that a specific group is less than. So you're a minority compared to whom? Okay, and in what context? So again, we want to be very clear about the terminologies that we use when we're talking to our patients, our participants, et cetera. In disparities research, we want to be very clear that when we talk about disparities, we oftentimes compare a group that we think is minoritized to the larger population or the non-minoritized group. But what we really are talking about are disparate rates of whatever the outcome is, right? And so it's not a disparity if your population or the subpopulation represents 65% of people in the United States and 13% of people who are living with HIV. Okay, that is disparate, but it's disparate in the opposite direction. It's a problem if you represent 13% of the population and 55% of people who are diagnosed with HIV each year, which is the situation for Black women in the United States. It doesn't always mean that there has to be a difference between people, and it doesn't always beg comparisons to other populations. So you can even do research within the subpopulation of whatever group of people that you're interested in and see that there are differences, okay? Disadvantaged. Again, this terminology is stigmatizing. Okay, so again, disadvantaged based on what? Is it social disadvantage? Is it political disadvantage? Is it financial disadvantage? And so it might change from time to time, right? So I might have been born in a disadvantaged state, and then through my education and opportunities, now I'm not quite as disadvantaged as I was when I was, growing up in Compton, California, right? And so again, thinking about the fact that a lot of times these positions are fluid and on a spectrum and are not static. So we'll talk a little bit about that as well. Same thing with the incarcerated. I do work with incarcerated populations as well. So we are trying to think of ways that we can not further stigmatize people who've been involved in the criminal justice system. Aliens, goes without saying. Goes without saying as well, right? So again, thinking of ways that we can be conscious about, and I really don't think a lot of people use these terminologies much anymore, but I did hear someone the other day refer to someone as Oriental, and I hadn't heard that in a long, long time. And I was like, where have you been? Right, kind of thing. And so it was shocking for me. Marginalized again. And then when we think about treating our patients, so, oh, this patient is non-adherent, right? So again, thinking about, is it non-adherence? Is it non-compliance? There are myriad reasons a patient or participant may not adhere. And most of these are social and structural. So what ends up happening is, as clinicians, we might end up putting people into categories of non-compliance, and then that impacts the ways that we provide care, whether or not we prescribe a certain medication, or whether or not we follow up in the ways that we would with certain other populations, et cetera. And then hard to reach. People are right there in front of us. So we use this terminology a lot, hard to reach, and now we're using terms like hardly reached, right? So again, there are certain segments of the population that don't want to be reached. You might think that you should want to be in my study. Like, you don't want to be in my study? Right? So again, it's what is it that we're providing to the community so that they're more likely to want to be involved in our studies? What is it that we actually are going to give back to the community when we involve them in our studies? Okay, so it's time to shine the spotlight on the terms used in research and care settings. So one of the sort of critical theories that I use is public health critical race praxis. And this was developed by Chandra Ford and Collins Ariambua. What it does is it requires that practitioners face our own biases from the outset of your research, from before you walk into that examination room, just tackle it head on, okay? Why is it that you hypothesize that sexual gender minority men are gonna have a ton of sex partners compared to somebody else, right? So again, even in terms of the work that I do, I have to be very critical of myself and say, okay, is this based on literature? Is this based on your own assumptions? Is this based on stereotypes that you have about gay and bisexual men? What is it? And in order to achieve health equity, it requires that we use new paradigms that address structural racism and its contemporary influence on health. So we know it's not race, right? And then thinking about health equities in research. So we have tools and resources that we can use to just be conscious of these things as we're entering the spaces with our clients, our patients, and our participants. So this is really tiny, and I didn't bring my glasses. I don't know where they are. Okay, so I don't know where, I thought I had them. Okay, so rethinking vulnerable and related terms. So again, I'm going to provide everyone with the slides if you'd like them. So if you're using terminology, so instead of at risk, groups who experience a disproportionate burden of poor health. And I said this before when I was doing the talk at Dartmouth, there's a lot of words. It's easier to say, boom, you're at risk. It's a lot of work and effort to say you belong to a group who's experienced a disproportionate burden of poor health. It's a lot, but it's worth taking the time, okay? It's really worth taking that extra step. And then also putting yourself in the shoes and being empathetic to our patients, our clients, and our participants. So unconscious bias, what is this? Here's a bunch of stuff. Out of shape, high income, female, white, masculine, gay, old, okay, etc. So when we use some of these terminologies, we use them oftentimes, and they are stigmatizing, okay? So what is unconscious bias? How to recognize it within our interactions, learn how unconscious bias impacts the individuals we support, and then provide tools to confront and change unconscious bias. So it's tied, think, inquire, do, and empower. So what is unconscious bias? These are learned attitudes of stereotypes that exist in our subconscious. Okay, so again, it's not necessarily I'm walking around purposely being, stereotyping people everywhere I go, right? So again, they're internal, and these are learned over time, and they involuntarily affect the way that we think and act. So we've heard the stories about looking at two resumes, and one of the names on the resume has sounds different from another name in the resume. And the unconscious bias that sort of results in that. Oh, this person might be less educated. They might not be a strong candidate for the job. Even using terminology like strong is oftentimes a problematic in terms of looking for people for positions in academia or whatever, okay? Why should we care? The benefits of tackling unconscious bias. It attracts diverse talent, leads to fair decision-making, encourages creativity and innovation, improves employee engagement, results in higher levels of productivity, and increases company revenue. Okay, so now we're talking dollars and cents, right? So again, when we tackle unconscious bias, or at least make an effort to be aware of unconscious bias, then these are the results of that. Okay, I had to slide up. So please, we could just talk about it here, or maybe you could pop it in the chat if you're in the Zoom. So what do you think of when you see this? And can we just get a show of hands? When you see this, what do you think of?
A person who needs a wheelchair to ambulate.
Okay, a person that needs a wheelchair to ambulate. Anything else? Yeah. Okay, some adaptation for someone who has a disability, has some sort of disability. Okay, anything else?
A closer parking space.
I was waiting for that. I was waiting. I was about to say, come on, it's like the closer parking space right at the grocery store or wherever, right? So again, thinking about people who are abled differently abled people, right? And that's on a spectrum. This could mean anything. It could be the closer parking space. It could be the person needs some sort of apparatus in order to be mobile, thinking about mobility, right? And all of these types of things, okay? Perception. That delinquent could save your life, right? So over here, same person. To the left, you'd be like, who is this guy? And then to the right, it's like, this is my physician, right? So again, judging a book by its cover, okay? So I remember getting trained to do STD training in San Francisco. And we, again, thinking about it, when you engage clients who might be, have, more sex partners than one, right? Then what would you say if they came in and they had a tongue piercing? So then we all went around the room. Oh, that they're not serious about life. Oh, that they're high risk. Oh, that they asked for it. All of these things and all this blah, 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 and all of these things. And what nobody knew was that evening I had an appointment to go get my tongue pierced. And so when I came back the next day, I couldn't talk. And everybody's like, so what happened to you? And I was like, oh, my phone pierced. And so again, I'm thinking about the fact that, yesterday it was a stereotype about people with their tongues pierced. And then here we go with, go on in life and do something with your life despite the piercing. So please don't discriminate. Perception of truth, boom, right? Stereotypes are awesome, but only one of them is a convicted felon, right? And so again, you got Snoop, and then you got his counterpart. He's fantastic, right? They're like some couple. I've seen like the elves on the shelf thing. I've seen the Snoop and Martha Stewart. It's called Snoop on the Stoop something. And it's too much. Okay. Again, what do you see, an apple or a pear? Right, so it's all about perception. Or one of those delicious plum cots. Have anyone experienced those in their lives? Delicious. Perception is everything, and the perception we have of others based on race, ethnicity, ability, or disability influences our judgment, okay? Types of bias. We have affinity bias, feeling a connection to those who were similar to us. Perception bias, stereotypes and assumptions about different groups. The halo effect, projecting positive qualities onto people without actually knowing them. And then confirmation bias, looking to confirm our own opinions and pre-existing ideas. Okay, and so we've all seen this in our lives, in practice, at our jobs, in our homes, with our friends, whatever, right? And so these are the different types of unconscious bias. Affinity bias. So this may affect maybe hiring decisions, or even who you decide you want to work with, or if you have a choice of office space, who you decide you want to sit next to. So a hiring manager gravitates towards a job applicant because they share the same alma mater. Okay. Over time, the affinity bias in hiring can damper a company's diversity and inclusion efforts. If we all went to the same university, we all studied the same things, we all know the same people, that's not diverse. So while eliminating affinity bias entirely is not possible, there are ways to reduce its effect. And this would be to create a diverse hiring panel, right? Or again, diversify your committee that's going to make a decision about who you're going to bring in next to the institute or whatever, okay? Go beyond hiring for culture fit. So the more hiring managers have in common with candidates, the more likely they are to evaluate them as a good fit. And even using terms like, oh, I don't know if they're going to be a good fit, is problematic, right? When you're thinking about bringing people in to your work environment, bringing people into your school, etc. Are you a good fit? What does that mean? Fitting into what? Okay. Perception bias. This occurs when we judge or treat others based on often inaccurate, overly simplistic stereotypes and assumptions about the group they belong to. Okay. This reduces the impact of perception bias, and it requires you recognizing your bias. So challenging your assumptions. So what I want you to do is ask yourself, how well do I really know the person or the group they belong to? Don't let preconceived notions prevent you from meeting people or including new people. You probably don't know as much as you think, right? So maybe just ask people, okay? And the halo bias. This is a term coined by psychologist Edward Thorndike. Occurs when we develop an overall positive impression, oh, this person is going to be really successful to the so-and-so because they look a certain way, okay? It may lead us to inadvertently put people on a pedestal and not even question their intent, not question anything they're bringing to the table. Person went to Johns Hopkins, they did the blah, blah, blah. Oh yes, they work with so-and-so and so, they're gonna be great, okay? The person doesn't even come to work, okay? And then confirmation bias. Confirmation bias is the tendency to seek out and use information that confirms your own views and expectations. So cherry picking information. And I told you it was like that. The one thing the person did that confirmed what you thought about them is the one thing that you hinge on. They've done a bunch of other wonderful things, but I told you that person was gonna be, that's the bad apple, okay? Here are some ways to encourage honest opinions in the workplace. You can use anonymous votes in surveys and things of this nature so that you don't have this type of confirmation bias. Okay, so all we can do is minimize or mitigate the bias. It's like bias in your research. It's going to be there. There's always going to be some random errors, some systematic errors and things. And the whole point is to try to mitigate them as much as possible. They're always going to be there. Okay, so you want to ask in advance. And then, of course, don't make assumptions based on someone's presentation. Okay, so I remember my first day as faculty, and I come in and, it doesn't matter. I could have on a badge that says Typhanye Dyer, keynote speaker. It doesn't matter. I'm going to get asked where the coffee is. So on my first day, someone asked me, like, oh, do you have the sandwiches? And I was like, who? I don't even eat sandwiches. I was like, but I'm the new faculty. I don't have the sandwiches. I don't know why you would ask me if I had sandwiches, right? So again, making assumptions about who I am and whether or not I am the person who does the coffee service at a conference and things of that nature, right? So we have to look at ourselves. So think about unconscious bias or a situation where you once had an unconscious bias. So let's think about that, right? And so for me, an example is again, the work that I do with sexual gender minority folks, right? And understanding that I am on the outskirts of all of that. And so I come in with bias and own it. You know, I don't know about this aspect of the community. So that's why I need you to be on this research team. Help me, help us. Okay. And then how do you change that bias? So again, Tide, think, reflect on interactions we've had with others. Were they respectful? Consider comments that don't reflect our beliefs or values. Inquire, ask respectful questions to avoid making assumptions. Sometimes not saying anything is a problem. You know, I know good and well you want to ask me the question, but you don't. So then I'm like, well, how come they didn't just ask me how to pronounce my name? I know it's kind of strange. My mother was trying to get creative. Okay. So you have to listen to gain information, insight, and understanding. Do something to acknowledge bias and shift perceptions. Okay. So a lot of this, again, is just being mindful. It's not a good thing, but it's not a bad thing. Everyone's walking around in the same world and we're all doing this all together all at once. Okay, we're in a relationship. Okay. So reduce the impact of bias, jokes, or comments. Okay. I've had that happen as well. It was supposed to be a professional thing. I was embarrassed. I was embarrassed for the people that were there because somebody said, had I ever gone someplace, Singapore or somewhere? And I said, no. And then they said, oh, they have really good, something that you might not think, they have really good fried chicken. Okay, so I knew, I was like, this is going bad. This is gonna go bad. And then they said, well, nobody eats fried chicken. And then she looked at me, she said, oh, well, you probably eat fried chicken. And I was like, what am I supposed to say? You know, this was someone, I'm junior, this is someone who's really, really senior to me. And so I was just like, okay, so now I'm stuck with what am I supposed to do with this information, right? And so again, do we acknowledge it? Did anyone say anything? No, right? And then empower, model and motivate courageous self-appraisal, okay? So TIDE, T-I-D-E. So these are ways that we can actually shift that impact of biased interactions with one another. What do we want to accomplish? We want access to healthcare for all. So I like this image because it shows what equity is, right? This is not equality. So it's not, okay, everybody's gonna get a medium-sized box, right? Well, for the little tiny person, the medium, I still can't grab the apple, right? So it's meeting people where they are, right? So equality versus equity. Equality concerns the absence of discrimination, while equity focuses on meeting people's health needs. So meeting people where they are, we all have different needs. So a not one size fits all approach doesn't take a static or dialectical approach. Dialectical or static is just like us versus them, me and you and I, right? It's looking at the totality of everyone within the context of their lives. The goal of each and every practitioner should be to achieve equity. But how do we achieve this? that particular video really exemplifies the ways in which structural sort of factors have an impact on people's ability to even get care, right? So again, when we think about access to care, it's like, oh, the hospital's right there, you can get there. But if all of these obstacles are in the way, then they might seemingly be close and at your fingertips. But if there's always something kind of in the way, then taking account for that when we're engaging our participants, our clients, our patients, et cetera. Okay, so how does equity show up in your work? Your research, your organization, your collaborations, or in professional and or personal interactions? So how does that show up? So you all have individual research teams, right? And so thinking about how we can increase equity within those teams. Okay, so bringing in people who are differently abled, right? Different racial ethnic backgrounds, different socioeconomic backgrounds, again, brings diversity. Okay, and the reason why, a lot of us do DEI things, and we added the B in terms of, belonging. So it's one thing to say, okay, we included people to be in the group, but how do you feel once you get into that space? Okay, how do you stay curious about how to engage in equity practices in your job, in your research, your organization, et cetera? So a lot of times what we do is we think about, okay, well, we can invite a Black woman to sit on the board and do all of these things. But when we think about the fact that intersectional spaces, then it gets difficult, right? So do we want to just invite people who are of different class, of different racial ethnic backgrounds, different educational backgrounds, et cetera, right? So this brings up for me intersectionality and identity. So your identity encompasses your memories, experiences, relationships, and value that create your sense of self. This amalgamation creates a steady sense of who one is over time, and it's on a continuum. So we know this, right? So I think we're being more conscious of the fact that one's identity today might not be their identity next year, right? So I identify in certain ways that in a year from now, I might not, right? So again, you're thinking of part of my identity is that I am an epidemiologist or I'm a researcher, this and that and the other thing. So if I change my job in a year, right, and I'm doing something different, then that no longer is a part of my identity, right? And that's kind of an easy sort of example, to be honest. Okay, so it often involves external characteristics, such as when a person has, I should say, for which a person has little or no control, okay? Such as height, race, or socioeconomic status. Okay. It might encompass political opinions, moral attitudes, and religious beliefs, all of which guide the choices one makes on a daily basis. Okay. Identity encompasses the values that people hold. And identity might contain multiple roles. Like for me, I'm a mother, I'm a grandmother, I'm a researcher, US citizen. And each role holds meaning and expectations that are internalized into your own identity, right? And so even though you might look just like another person, your identity could be completely different. And so even making assumptions that, oh, we're on the same page, because you might not be, okay? It's fluid and on a continuum. And, people, have different opinions about this, but they are fluid and on a continuum, and they continue to evolve over the course of your life, right? So it's not like, oh, I made it. I know my identity now. I'm done, no, there's no finish line, so it could change over time. Intersectionality. Because of the intersectional spaces that people occupy, stigma often abounds and impacts one's ability to access services that are seemingly available. Intersectional stigma, discrimination, racism, homophobia, xenophobia, biphobia. And this is all based on an underlying assumption of heterogeneity within our population, and that we're all just kind of the same, okay? Stigma, we know, is a social phenomenon that contributes to health disparities, okay? And this is particular in the work that I do with respect to bisexual and same gender loving men, right? So 4 concepts: labeling, stereotyping, separation, status loss, 5 concepts, and discrimination. So what is labeling? We know this. In most cases, it implies attitudes of social exclusion and rejection. So labeling theory explains how others perceive a person's behavior, or in this case, identity. Then based on that characteristic, they label it within the social and cultural conventions. So it's as if you're labeled, you're different, you are deviating from the norm, quote unquote. Stereotyping, we know, often used to describe negative behaviors in society that are directed towards a specific group of people. Also, sometimes known as shaming and stereotyping. So we know some of the labels that we put on people, this goes back to labeling, lead to stereotyping and shaming. Okay, you're different, you're other, and othering. So when a person's labeled by their illness or status, they're no longer seen as an individual, but as a part of a stereotyped group, right? You're HIV infected. Okay, and so then they're left with the job to say, well, who am I if I'm not my HIV? I'm all these other things. I'm a mother, I'm a grandmother, I'm a teacher, I'm a lot of other things, okay? And then othering. So this is stigmatization in which you exclude those who are perceived to be a potential source of disease. So you're othered in a way. So if someone says they hate the disease, in essence, they're saying that they hate you because they've also labeled you as someone who's HIV infected, right? So again, it sort of leaves up to the person to say, well, what is my worth? If you say that you hate something that I have, then by and large, I'm going to assume that that means that you hate me, okay? And it's left to the other person to disentangle that part of themselves that's different from that disease or that. Minority stress is a theory that was developed by Elon Meyer in 2003. And so again, it sort of links on with intersectionality, right? So if you are both, say an African-American gay or bisexual person, then you would experience dual minority status, okay? And so again, I'm thinking analytically how we model that and all those things is not really important. And there are 3 processes of minority stress: internalized homophobia, and then also anticipated stigma. We use intersectional frameworks to help us understand some of these things. And again, the whole point of this is how do we better understand people in the positions that they occupy, the multiple social positions that they occupy, so that we can provide better care for them, so that we can ask the right research questions with them, so that we can have a better understanding of what are the interventions that we need to develop so that we can have the greatest impact on people's lives, okay? Again, intersectionality. We know Kimberly Crenshaw, Bell Hooks, we've got Patricia Hill Collins, we've got Sojourner Truth, Ain't I a Woman? And I won't get into the weeds about it, but there's a carriage of some sort. And so somebody walks up, opens the door, lays down the jacket over the puddle, and the white woman steps out and then closes the door on Sojourner Truth. And so she's left to say, well, ain't I a woman? Right? Well, you are a woman, but you're a Black woman. So again, so that sort of denigrates you to another social position outside of, kind of your womanness, so to speak. Dr. Lisa Boleg wrote a paper, once you've blended the cake, you can't take the parts back to the main ingredients, right? So again, you're blended cake, right? And so you can't take off the hat, one day, well, when I enter this space, I'm a woman. When I enter this space, then I'm Black. When I enter this space, then I'm queer. When I enter this space, it's like at all times, all day, every day, I'm a Black queer woman, and that's all there is to it, right? And so you can't disentangle the parts. And as practitioners, as researchers, it is our jobs to understand that these are the social positions that a lot of our clients, participants, patients occupy, and to just be aware of that, okay? And maybe even taking a step back. Okay, so say for instance, you are not well-versed in providing care for trans feminine folks, okay? And, or trans masculine people, say for instance, and a trans masculine person comes into your office, but they're there to get, get a pap smear or something, right? And so again, as a clinician, it'd be okay to step back and just kind of reassess sort of what's going on before you say, I think you're in the wrong office. What are you doing here? What's going on? Like the person knows where they're supposed to be. And so it's our job to actually kind of maybe take a step back. Intersectional stigma. So this is a concept that's emerged to characterize the convergence of multiple stigmatized identities. So all of this kind of hinges on intersectionality. We've got stigma, stereotyping, labeling, et cetera. Okay. And this also alludes to some synergism. So I'm not going to talk about syndemics, but when you think about intersectional stigma, it's kind of the same, right? So they reinforce all the stigmatized identities, they reinforce one another, right? Intersectionality and minority stress. So again, thinking about how these two frameworks work together and help us understand how to provide the care and do the research in the communities that we want to have the biggest impact on. How do these manifest in the healthcare setting? Inadequate or delayed treatment due to misattribution of symptoms, refusing to provide care information or treatment based on the belief of the patient's or client's beliefs, having a lower expectation for health outcomes for patients with substance use disorders. So a lot of the work I do is in drug dependence and infectious disease epi. So thinking about, even when we're thinking about inclusion and exclusion criteria for our studies, we're really pushing NIH now to say we need to include, pregnant women, right? Obviously we have to be ethical about this, but we're excluding a certain segment of the population for which a lot of our findings are completely, understandably, I can't think of the word. Important. That's the only thing I come up with. Okay. Also believing that a patient who returns to using while participating in an SUD treatment program is undeserving of treatment. So providing equitable healthcare that meets the needs of patients and clients is central to public health. Static versus dialectical. So again, not an us versus them, okay? Dualistic perspectives, body, mind, men, women, et cetera. So think about the context within which these phenomena are occurring. It requires that we are culturally sensitive. So cross-cultural sensitivity, cultural competence, cultural awareness. I say tomatoes, I think not. Cultural sensitivity. It's not only knowledge, which is competence, not only awareness, which is cultural awareness, but it's accepting cultural differences, your practices, your identities, your behaviors. So examples, I got this person here who's cutting hair, right? So a lot of the work that we're doing in Maryland, we're engaging people at the barbershops. Okay, you want to get Black men into the studies, or, we're going to the barbershops and having them do peer outreach with their clients as it pertains to STIs and actually for vaccinations as well. So understanding and being empathetic to cultural differences. Cultural sensitivity is empathy, compassion, and it's relativistic. So it's not only awareness, but the experience of one's own culture and ethnicity. It's not absolute, but it's in relation to another's experience. So it's relativistic, right? And it's also requires that you are humble. Cultural humility is a self-reflection on how your own background and background of others impacts the way we engage them. It's an ongoing process of self-exploration and self-critique. So a lot of this feels like, you want me to, it's a lot of it is being self-critical. Like Typhanye, you shouldn't have said that. You put your foot in your mouth. Yes, you did. It's bi-directional and it's continued. Again, it's not like, whoo, I got it. I'm culturally sensitive today. It's like, okay. Yeah. So it's an ongoing journey. Like you're never there, right? And because people's identities change, then it requires that our understanding of that change also changes as well. So it can be like, well, last week it was something, right? So it requires this ongoing lifelong learning, okay? Self-reflection and criticism. Recognizes that within many disciplines, professionals must consider and address our biases. Some people believe that combining cultural humility and competence helps practitioners work more effectively, and we're better equipped to work with unfamiliar populations when we have prior knowledge about their cultures. And you can't learn everything about everybody all the time, right? But it's helpful if you have at least baseline understanding of differences in different cultures and how that may impact someone's use of services or their ability to adhere to medication and things of that nature. So what can we do? Enter the space aware of biases, confront them head on, Be mindful of the biases, which don't go away overnight. Utilize active listening with your patients. Be open and honest in the case that you're unsure of cultural practices and beliefs. I'm not sure what goes on during whatever. So help me understand. And I understand that when you're with your patients, your clients, your participant, you don't have all day. Nobody has all day to do the whole, I have 30 minutes to now learn about your culture, right? So some of this is what you're going to be doing behind closed doors and being like, let me just kind of up my game and try to understand, the population that I'm working with. And don't err on the side of caution. So a lot of times being too cautious, can be off-putting for people. So we get a lot of transgender women who say, my physician doesn't even talk about PrEP with me. And then some are like, that's all my doctor talks about is PrEP. They're assuming that I'm out there on the streets having sex with everybody, so I need to be on PrEP, right? So darned if you do, darned if you don't. Should we talk about the PrEP? Should we not talk about the PrEP? Or should I assume that you need the PrEP? What is it, right? Refrain from language that others and stigmatizes your people. I don't know if anybody would say that, but your people. Transsexuals, okay? Learn any nuanced terminology for specific groups of people. This always changes, okay? So the work I do with our Prevention Research Center, we're the only PRC that does mental health for what was LGBTQ. Then it's LGBTQ+. Then it's LGBTQIA2S+, right? And so it changes over time. And so again, think about the nuanced terminology. I was saying transgender women, and then somebody hit me last week and was like, no, it's trans feminine. Two-spirited, LGBTQ, lesbian, gay, bisexual, transgender, intersex, asexual, two-spirited. Yes. And then there's a plus. Yes. I did say it that. LGBTQIA2S+. Everybody's like, what are you? Nobody said anything though. Everybody's like, we won't say nothing. Yeah, you did. I'm gonna ask. Again, this is the example. I don't know what that is. So help me understand what that is. Okay. So I always think of putting yourselves in the shoes of your patients. How would you want somebody to treat your elderly, father? Right. Sociocultural barriers to healthcare. Organizational barriers, structural barriers, clinical barriers. So these are system level barriers. What are organizational barriers? They affect the availability and acceptability of healthcare for culturally diverse patients. So again, we think about when you walk into the healthcare space, is there literature in your language? Are there pictures on the wall that represent the people that you're serving? Okay. Structural barriers to healthcare, communication, the absence of interpreter services, increased wait times among culturally diverse populations, etc. Clinical barriers occurs in patient-provider interactions, okay, if there are sociocultural differences, and they might lead to mistrust and distrust. So medical mistrust, I'm not going to read the whole thing, is you're not trusting the medical system based on something that happened that didn't really happen to you in your life, right? So I think about Tuskegee, Henrietta Lacks, et cetera, et cetera. Okay, distrust is a lack or faith in someone based on knowledge. Like, no, when I came in last week, you told me to do this, I did it, kind of thing. So it's based on your own personal interaction in the healthcare sphere. We need to win back trust. It requires work. And then it requires us to go back to equity. So thinking about what the difference between equality and equity are. These are some metaphors. The important parts are fair opportunity. No one's disadvantaged. Every person has an opportunity. Fair and just opportunity, removing obstacles to health. Okay. So when we think about how do we define health equity, these are some of the ways. Fair access to conditions and opportunities, removing barriers. So we already talked about these things. These are components of a health equity definition. Health equity is aspirational, represents a commitment to reduce and eliminate health inequalities or inequities, and health inequities data measures progress towards health equity. Social determinants of health are important as well. Distal and upstream, we have structural, societal, all the way to biological, okay? This is where policy comes in, right? You think about structural and community environmental kind of things. Walkable sidewalks. I live in a neighborhood that has no green spaces. No people are physically active. There's no pool in my neighborhood for the children to swim in, et cetera, et cetera. Or I live in a food desert. There's no food at all. Reflect and share. Why is using shared language critical to advancing health equity? So again, having a shared language with the people on your board, on your staff, on your team, so that you understand how equity is being shown in your organization. So if we speak in the same language, then we both know that when people walk through the door, that we don't start whispering, or that we make sure that we say, you know, greetings, can we help you, whatever the thing is. So there's no misunderstanding. Yes. So yes, okay. So organizations must understand the cultural and political resonance of racial and health equity concepts within your communities. Understanding conscious bias, knowing what it is, how to deal with it, and just being conscious of your unconscious bias. Yeah. Thank you very much. I need to thank Dr. Fowler for inviting me, and thank you for your attention and for your laughs and your smiles. I can see your faces and it really makes me feel happy. And so thank you very much. And thank you for asking that question. And I was hoping I got it right. I was like, yeah, thank you very much. Thank you. Yeah, do you have any questions about anything? Yes. Oh, well.
Hang on. Thank you, Cameron.
I forgot about
They want to know, is it still appropriate to say of trans experience? That way it removes the gender affiliation. They know that they speak to different people and everyone has different preferences.
Yes. So someone of trans experience is appropriate for all of those reasons. So it removes the gender from it. So, and I've heard again, so I was at another meeting and someone said, yeah, so trans feminine. I was like, ooh, so we're not saying transgender women, right? And so people of trans experience is more appropriate. Yes.
So I sometimes refer to assimilationists. And as I was listening to you, I was thinking, that's probably wrong, because I'm labeling someone who wants everyone to be the same. And I don't know that we as scientists, like everybody should be healthy, everybody should have access,
Yes.
everybody should assimilate to what makes American culture comfortable. But is that a label?
An assimilationist? It is a label, but I think, so again, we label things a lot, right? So what you've just done was be very critical of the fact that, okay, so when I say assimilationist, is it okay? Is it a bad thing that we are striving for some, you know, this world where we're all healthy, where everyone has an equal opportunity to do all of these wonderful things? I would say that is a label. And the reason why I say that as well is because if someone said, oh, you're an assimilationist, I would be like, whoa, is that a good thing or a bad thing, right? And so again, I think it's almost like, I didn't include this slide, but where we talk about where people say, well, I don't see race, and it's like, well, some of what differentiates us is what makes kind of us what we are, right? And so everyone's not going to have equal access. Everyone's not going to have the best of everything, but that's sort of the gold standard, right? So we're striving towards that. But does that mean you're assimilating to cultural expectations in this country of what it means to be healthy and to have all those wonderful things? So yeah.
So I have a question that's more methods based.
So when we say, for example, in social and behavioral interventions, we're designing them and we are then asked by NIH reviewers to do, subgroup or sensitivity analyses around different populations. How can you make that feel more genuine and meaningful?
When you are asked by NIH or anyone,
or
like
anybody,
a review.
if somebody asks or says, well, you tested an intervention and, 60% of your population identified as white,
Mhm.
30% identified as African American, 40%, were below a certain threshold
Yes.
for economic income based on the area deprivation index. So you have different information about your population, and you really want to truly understand how it can be, how your interventions different in different groups in a way that's meaningful.
Right. So that's a really good question. So one thing that you could do is, from a methods perspective, I think, is you could either push back, or you could say, well, we've done some within group. What I would do is actually look within each of those strata of categories. I would look for within that strata, with the 60% white people, the 30% African American, and see whether or not there were differences along whatever variables it is that I'm interested in. So I could just say, well, we see some really stark within group differences as well as between group. But that's a problem. I think that's problematic. I mean, I get the same thing if I control for something and I say, oh, I controlled for this. And then I get someone to say, well, I really want to know. You controlled for incarceration. I want to know what's going on with the incarcerated folks, right? And so now what you see are these tables that have all of the covariates actually in the table, so you can see across all of those covariates the differences between the subpopulations. But I think that's an issue. I don't. Yeah. Yeah. I mean, in terms of how to make it more meaningful, it's all about, how to. Yeah, that's a tough one. Yeah, how
I
to.
didn't want to end on that
Yeah.
stumper. I
No,
apologize.
it's okay. It's okay. No,
Yeah.
that's a really good question. Right.
Well, again, join me in thanking Dr. Dyer for coming and giving such a fantastic
Thank you,
presentation.
everybody.
I'm so happy to have you.